early orthodontics, could versus should, general dentists and pediatric dentists, what are the things they should be able to do and what are the things they could do. So these things, we won't go into complete details of all the procedures, but this is the main. I'm going to present the clinical scenarios where we can do something, we should do something, and where we could do something. So hopefully you're going to enjoy this presentation. So I would like to also inform that this presentation is made by my colleague Dr. Dua, and I've taken her permission to present this to all of you, inshallah. So what are the things that a general dentist and a pediatric dentist should be able to do? The first thing what we expect is to detect a problem at an early stage. First, detect and you diagnose a problem, and they could treat depending on the level of training, experience, and comfort of the clinician, the amount of guidance, and also help from an orthodontist. So there are places where you need guidance, and there are places where you can be, if you have experience, you can go ahead and do it on your own. So the main question what we deal with is whether we should treat, that's the dilemma what we have, good, or should we treat it good, or should we treat it now, or should we wait? So these are the dilemmas which we, as a general dentist, when I was general dentist, I used to have it, and I believe most of the general dentists who are seeing these cases, they have a dilemma whether they should treat it now or they should treat it later. So early orthodontics. So what is early orthodontics? I mean, early orthodontics you can classify as like a phase 1 orthodontics. Phase 1 orthodontics, what it could include is interceptive orthodontics. Also, it will include preventive orthodontics. So if I give you the definition of details about the definitions and everything, it's just a very simple terms from the American Association of Orthodontics. It says interceptive orthodontics simply means you diagnose and treat malocclusions as soon as they are detected. When initiated during the incipient stages of a developing problem, interceptive orthodontics may reduce the severity of the malformation and mitigate its causes. However, if we have any complicating factors like skeletal disharmony or overall space deficiency, which needs comprehensive treatment, that you could leave it for later. But what are the advantages, or first of all, what you could do is you can provide an optimal dental health and function, and you could give fewer extractions remediated in future if you intercept early. And also, there could be reduction in the duration and difficulty of subsequent treatment, and there could be fewer treatment risks. We could, in certain cases, completely eliminate a phase 2 of treatment. Having any orthodontic surgery or comprehensive treatment if you take few steps at the right time. And we could improve the facial aesthetics and patient self-image. It's very important, where a lot of people who will have some sort of psychological issues can be there with the social acceptance, which could be improved, inshallah. So there are certain conflicting evidences regarding the psychology of the malocclusion, where one of the papers it says that interceptive orthodontic treatment instigated in adults being bullied due to the presence of malocclusion may have a positive impact on oral health. But what are the disadvantages of doing early orthodontics? It's like a phase 1 treatment, as you can see. Most of the time, so if you do treatment something initial, so you need to have a later stage treatment as well. So you could need a second phase of treatment may be needed, and there could be a longer overall duration. The patient could burn out. So it's just so many years of treatment going on for years together. The patient have a burnout, and it could end up having a high overall cost. And also, last but not least, is you need to have a prolonged and monitored retention. So these are the things. So you need to have a phase 1 and phase 2, longer duration, high cost, and prolonged retention. So these are the disadvantages. There are, as I said, the conflicting evidences. That there's a paper done by Shaw and Richmond which said that lack of orthodontic treatment when there was need did not lead to psychological difficulties in later life. So depending what sample, what is the culture behind, there are the things which could affect the children. But I personally believe that interceptive orthodontics should be done wherever there is needed, and it's informative results. So I'll give you certain examples. In this situation, the patient is seen in our department, so who had a mesiodense, and which was monitored from years together. The OPG had shown, if you see there's a mesiodense there. and it was present in the OPG years before he was seen in with the orthodontic department by us. Had this been treated early and picked up early, if you could see there that the patient had double mesoderms. There's an inverted tooth there, so we have an inverted tooth there, you can see here, and also we could see that there is an erupted tooth here, and there's another. So we did successfully remove the tooth eventually, and alhamdulillah he is pursuing his treatment, and sometimes as simple as giving a space maintainer would prevent a lot of problems. So for all these things, what of triage is where you know your capabilities, where you could identify what can be done, and if it is in your capacity you deal it, if you're not in your capacity you at least pass it on to the others or train. So this is a chart which we brought out to have like a systematic system of triage. So we will look into each inshallah one by one, and we'll see what we could do and what we should do and what we could not do and we shouldn't do it inshallah. So first let's go to the syndromes. So if we have syndromes and developmental abnormality, one of the things what we say is if you see any syndrome, better to refer to a specialist, but they will need more comprehensive treatment, and sometimes they will need a multidisciplinary team. So it's best not to be treated by a general dentist or by a pediatric dentist comprehensively. If anything which needs dental attention, it could be addressed, but as an overall, so this is a case which needs to be referred. Any cleft lip, palate, Toucher-Collins syndrome, hemifacial microsomia, or this any facial symmetry, we just refer because this comes under complex. So if you see facial profiles, so for patients, so if you identify a patient with short face, or if you identify anybody with a high angle, or having a skeletal class 3, skeletal deep bite, so these are again, it comes in the category of complex problems. So you wouldn't want to do something to make it more worse. It's better to refer to a specialist who can deal better in these. So if you have facial profile problems, if these patients having a long face, you can wait. So there's no need to rush and do something. And even if it is a short face, we could wait until the eruption of all the teeth are erupted, and we could see exactly, we could diagnose what is the problem, and then we could treat them. And even if it is class 2, we could wait until the close of adolescence. But if it is a class 3 due to deficiency of maxilla, it has to be addressed early. So this is something which we have to pick it up. So if you see it's retrogalactic maxilla, it's better to do something to protract the maxilla and catch up the growth to prevent further. Wise, if you see the growth, the cephalocaudal gradient of growth, where initially the fetus, there's a larger head and a short body, but however, as we grow, our limbs and the lower body grows at a faster pace, whereas the head remains more or less kind of a constant and is in vertical growth direction. And as we see this cephalocaudal growth, so we have similar growth pattern which you can see in the face as well. Where is the lower half of it is the mandible, it continues to grow more than the maxilla. So whenever we have like a situation where there is a class 2, so we could take a chance to wait for long because the mandible grows longer than a period of time than the maxilla. So we could initiate the growth of mandible during the later period of time. But on the other hand, if we have a situation where the mandible is growing at normal pace and the maxilla is not, it's better to protract the maxilla, initiate the growth of maxilla early so that we could catch up with the mandible. So that's why it's better to identify what type of treatment could be done. Spines. So especially when you do the trapped teeth, so in 8 to 10 years old is the ideal situation where we would like to go ahead and do something. So as soon as the thing is, if you see a class, make sure you refer, and so that something can be done initially. So coming to the occlusal discrepancies. So what are the things you see in occlusal discrepancies? If there are no other complicating factors like a severe crowding or a lateral shift, so we could classify that as a moderate problem. So in this case, we could delay it until the late mixed dentition, but not later. So we won't go ahead and take the advantage of the expanding bone, so that we could guide the premolars and second molars into occlusion, and we would need a lighter force to be used. But however, if there is a lateral shift or if there is severe constriction of the arch and causing space problems, then it becomes a complex problem, and this should be probably we could treat it more earlier. Anterior crossbites. So even anterior crossbite, we need to identify the cause of the problem. So not all anterior crossbites have a universal cause. It could be skeletal problem, it could be functional shift, or it could be a simple displacement of the tooth. So if there is a skeletal problem or there is a functional shift, then we could classify it as a complex problem. So we would probably refer it to the specialist. But however, if there is a displacement of the tooth, where there is a high point, there is a contact, where the child is deflecting, so the moment you reduce it or you deal with it, there is a high possibility that the crossbite and the attachment of maxilla could be prevented, and the maxilla could have a proper growth. So the anterior teeth crossbites could be due to displacement. Usually, why do we have displacement? That one of the reasons could be the lingual displacement of the tooth bud. It goes lingually. It could be a supernumerary tooth. If there is a supernumerary tooth, but rarely due to trauma to primary tooth and lack of space. So if there are any supernumerary tooth, then it tends to become a complex problem. So if you could address it, you could address it, or if you prefer to refer, we could refer it. So coming to open bites. So what are the possible causes for open bite? So things, the normal transition when primary teeth are replaced with permanent teeth. So that is, you see a little bit of open bite, which normally it resolves by its own. But sometimes you have moderate problems like habit finger sucking, or which dissolves it sometimes. So if the patient stops the habit, so it can resolve on its own. So we need to encourage the child to want to stop the habit, or we could give them certain kind of appliance to help them to stop the habit, which if it's in the right time, the malocclusion, the open bite could reduce on its own. So if the habit cessation is before the eruption of permanent teeth, then it could resolve on its own. If not, then you would have to give a habit breaking appliance. But if it is a skeletal problem, then it becomes a complex problem. So then you don't go ahead and do something. So probably rather refer to a specialist and then let him deal with this. So coming again to the next occlusal discrepancy, deep bites, most of the time they are the complex problems. So you wouldn't go ahead and treat them immediately. Rarely we address it during mixed dentition, except if it is a traumatic bite where we could give some sort of pipeline to address it. Because as the teeth are erupting, so we need to understand whether it is a lack of eruption of posterior teeth or it's over eruption of anterior teeth. So this becomes a comprehensive treatment, whether it is true reduced to lower facial height or the maxilla is overgrown. So we have to do full diagnostics before we could embark on the treatment of deep bite. So next on our triad system is to look for the dental development. And this is where I would say is the most of general dentists and pediatric dentists can give the eruption problems. If you see eruption problems of 6 months or more between the two quadrants, then something has to be addressed. So normally, why do we have eruption problem delays? It could be either radiation therapy, traumatic injury, dilacerated roots. Now all this comes under moderate to complex. So we need to make sure that there is no other reason that is hindering the permanent tooth from eruption. Normally, the permanent teeth has a favorable path of eruption, so we need to monitor. So if you see anything, selective extraction of primary teeth, when you would carry out, when you see there's at least 75% or 3/4 of the successful root is formed. So until then, probably it's best to wait and monitor the situation. Like we see in this case here, if we just blow it out a bit here, canine is probably going to be ectopically erupted, or probably it could be potentially impacted, so where you could carry out selective extraction of the deceased teeth or the primary teeth to correct the malocclusion. So if you look at the X-ray here, we could see here that there is a the tooth which is ectopically erupted, which is central incisor on the left side one. The second situation what we commonly encounter is a missing permanent teeth. The most common missing tooth is maxillary lateral incisor and mandible second premolars. So when you see certain where there is a missing permanent teeth, then we could classify as a complex treatment. So where we need to decide whether we need to close the space or open the space, So in these situations, it's best to be referred. If this ectopic eruption is on a permanent tooth causes either resorption of a primary tooth other than what it is supposed to replace, or resorption of an adjacent permanent or primary tooth. So again, ectopic eruptions, it could be classified as a moderate to complex that needs to be investigated as soon as it is noticed. The lateral incisors, the resorption of the primary canine root or loss of the primary canine. So it indicates, mainly there's a lack of space. So if you see there's only one canine is locked on one side, it could lead to midline shift. So we need to do something to treat this situation with this early loss of a primary teeth. So with the lingual arch with spur, or we could extract a contralateral canine. These type of problems are better dealt in a specialist or a pediodontist with a good background experience, I would say. So probably you need to give a lingual arch with a spur to prevent. So another clinical scenario which we most commonly see is ectopic eruption of maxillary first molar. So where we see that the maxillary molar is causing the resorption of the secondary primary second molar. So if the resorption is very mild, so you could opt to just monitor it closely for 6 months. So if you see in this situation, here, so there is a kind of more than mild resorption, so it looks like it's unlikely it's going to erupt. So we need to provide some sort of guidance for the molar to erupt. So normally there's a guidance. So one of the ways is if this is partially erupted the molar, you could give a brass wire separator or a steel screen separator, or the easiest way would be to just put elastomeric separator, where you could use a floss to thread through the separator, pass the floss between the contact point and pull it through so that it gets wedged between the contact below the contact point. Because you could tie the two separators together and then take the floss, expand it, pass the floss between the contact point and pull it, so that gives that a push enough to deflect the molar and help it in its eruption. If that is not working, then sometimes we'll have to extract the second molar, and maybe later on we need to distalize or gain the space for the lost space because of the mesial migration of the first molar. So you would paste the separators only if the permanent tooth is erupted in the oral cavity, but it's not complete. What we see is this most common scenario to see is the maxillary canines. So the first thing as a general dentist or pediatric dentist is to see that whether you can feel the canine bulge at approximate age of 10. If there is no palpable canine bulge, it is indicated to take a panoramic radiograph. You see and you assess the problem, whether they are in a favorable position or in an unfavorable position. Early diagnosis and intervention is crucial. So we need to check whether it is causing resorption of lateral incisors. So if you look in this scenario, it's most probably it's causing a resorption of that. So this could be classed as a moderate problem. The complex problem is when the lateral incisor root is resorbed, or it is more ectopic, where you don't think the extraction of primary canine would help. Then surgical exposure and orthodontic traction of the permanent canine is necessary. So before this, we need to have more diagnostic record and more comprehensive investigation to be done to locate the canine and the extent of damage to the other teeth. So it's best to be done. Again, supernumerary teeth. Again, most common location is your anterior maxilla. So it could cause disruption of the normal eruption, or it could cause crowding, or it could cause spacing. So our aim is to extract before the problems arise, or at least we minimize their effect. So we would say the situation is moderate to complex. It is moderate if it is a single tooth, and complex when there are multiple teeth. But even with the moderate, we need to make sure that the patient is informed that the patient would need probably a surgical and orthodontic treatment. The more longer you need to leave it, it's more likely that he would need more complex treatment. Sometimes the supernumerary teeth which could delay the extraction. So what are the reasons to delay the extraction? One reason it could be to allow the further growth to improve access. If it is very deep in the bone and you think that the access would make it more difficult, so you would rather hold on to it. So better tolerance in surgery, further root development of the remaining teeth to ensure better progress. We have an ankylosed primary teeth without the permanent successor, what we see sometimes or most of the times. In that case, what can happen is we could have a vertical bony defect. So if the treatment with this, if you see here, there could be discrepancy, the space is being encroached, could lead to crowding. So the treatment would be to extract before a large occlusal discrepancy occurs. So you need to give a space maintainer and a refer. And as the teeth move, they bring along the alveolar bone with them. So you move the adjacent teeth, the bone defect would be corrected. So coming to our last section in our triage, which is the space problems, and we quickly wrap this up, inshallah. What are the points to consider? So what is the things? The main thing is, what is the space available? What is the space needed? And also we need to look into the profile. So if we have a situation where there is a tooth lost, but we have an adequate space, the best is to maintain the space. And also if you're expecting the permanent tooth to erupt within 6 months, so you wouldn't need any more further treatment and the teeth would erupt. So coming to the types of appliances, you could have a band and loop appliance where you extract the primary molar and you could just put a band on the permanent or deciduous molar depending on which tooth. You could give partial denture. So if we are extracting second molar before the eruption of first molar, then you could give a distal shoe, or you could give a lingual holding arch, and all this could be classified as a moderate problem. So if you have mild to moderate crowding of incisors with inadequate space, so if you have mild to moderate crowding of incisors with adequate space, that there is no arch length tooth size deficiency, so which could be like a moderate problem. So what you could do is like up to 3 mm of incisor crowding in mixed dentition can be resolved spontaneously. So sometimes you would need to do a disking of the primary canines, and sometimes you need to make use of the leeway space to allow the correction of the crowding, and you would use lingual holding arch before the primary second molar exfoliates, so that you could use the leeway space and also correct the molar. So another most common situations what we see in our clinics is a midline maxillary diastema, midline diastema. If it is 2 mm or less, so most of the time we would see in this in an ugly duckling stage, and which would correct spontaneously. Sometimes you could give an active Holly appliance to close it, but however you need to be very cautious in giving any appliance. Most of the time it would correct on its own. So if it is more than 2 millimeters, so you could classify as a moderate problem, then you would still refer to orthodontist. One of the reasons you need to be very careful with having any appliance during mixed dentition is that you don't want the root of the lateral incisors to encroach into the canine, and it could cause the resorption of the root resorption. So if it is more than 2 mm diastema, so it could be a moderate problem, so you've got to be careful and then investigate it further, what is the reason, and deal with the reason appropriately. We could classify as a complex problem if there's any supernumerary, or if there's a missing lateral, or if there's any thick renal attachments which needs further treatment. So this is the most common scenarios what we see where we could do the intervention and where we should do some intervention, and we know our limits. So coming to the last slide, the take-home message is that the American Association of Orthodontics is recommends that as an orthodontic checkup. So you check for the occlusion, you check for the teeth, you check for everything, and no later than the age of 7. And early treatment should be provided when it is crucial. So you have a triad system in place and the list of problems that you are comfortable treating with. And when in doubt, please refer. For you all. So again, I thank you, everybody, the team of KMD, and everybody who's watching this video. Some more contact details if you want further information. I'll see you again. Until then, Assalamu alaikum wa rahmatullahi wa barakatuh.